This is Chapter 13, which deals with the peripheral nervous system. With the peripheral nervous system, this is everything that is outside of the brain and the spinal cord. So it's going to be kind of that link that connects the sensations and what's going on outside of you, that environment outside of you, and relaying that information to the brain so that you are consciously then aware of what's going on. It connects basically your receptors that are picking up sensations to the brain so it can analyze it and decide the appropriate response. So we're going to look at all aspects of this. The peripheral nervous system can be divided, as many things, into subdivisions, etc. When you look at the peripheral nervous system, first you can divide it into the sensory or afferent division and the motor or efferent division. The sensory is providing that information from all the receptors about what's going on in the external environment, and it is sending that basically towards the peripheral nervous system. So information is coming in. The motor is going to be the response. So it's coming from the peripheral nervous system, and that information is moving away from the peripheral nervous system towards the extremities. Typically, it's giving the information of this is what you have to do. So it's the response. The motor division itself is then divided into the somatic nervous system and the autonomic nervous system, and we're going to talk about all of these. The somatic nervous system refers to basically the response by the skeletal muscles. The autonomic nervous system, which is often abbreviated as ANS, as the name implies by autonomic, it is involuntary. And then that itself is now broken down into even two smaller divisions of the sympathetic versus the parasympathetic. We're going to start looking at the sensory receptors and how they pick up various sensations. So the sensory receptors are very specialized to respond to some change in the environment, which is what a stimulus is. So if it's specialized to pick up a change for cold temperature, it will not detect hot temperature. They are that specific. How are these receptors activated? It's going to result in a greater potential that then ultimately triggers the nerve impulse. There's a difference between sensation and perception. Sensation is awareness of a stimulus, and then perception is the interpretation of what does that mean? What does that stimulus mean? And that's going to occur in the brain. As always, there's lots of different ways that we can classify the receptors. They can be classified by the type of stimulus, by the body location, and by the structure of it. So if we classify them according to the stimulus, you have mechanoreceptors that respond to touch. Some will respond to pressure, some to stretching, some to vibrations. Thermoreceptors are sensitive to changes in temperature. You have hot thermoreceptors and cold thermoreceptors. Photoreceptors respond to light, such as what happens in the retina in your eye. Chemoreceptors are going to respond to chemicals, such as smell or taste. Nociceptors, these are sensitive to pain. So if there's excessive pressure, if there's extreme hot or extreme cold, chemicals that cause inflammation. Classification by location is exteroceptors. They respond to some stimulus that's coming from outside the body. Temperature, touch, most of your special senses such as vision, hearing. Interoceptors or visceral receptors are responding to stimuli internally. They may be sensitive to chemical changes. They may be like sodium concentration changes, stretch, internal temperature changes. Most of those are going to be stimulated, and the response, everything is generated, and you are totally unaware of it. It's in your subconscious. Proprioceptors respond to stretching in the muscles, with the skeletal muscles, the tendons. It makes you aware of the movement. Yes, I am stretching out my knee. In terms of classification by the structure, the majority of them respond to one of two, either simple receptors, or which are typically for the general senses. They're found throughout the body. There are receptors for the special senses. Special senses are vision, hearing, equilibrium, smell, and taste. And those are going to be, as it says, housed in complex sense organs. So like your receptors for vision are going to be in your eye, in the retina. These receptors for hearing are in the inner ear. Equilibrium's in the inner ear. Smell, it's going to be in the nasal cavity, and taste is going to be in the taste buds, mostly associated on your tongue. We have a special chapter that we will discuss that. The simple receptors for those general senses often include tactile, which is touch. Receptors tend to have either free nerve endings or encapsulated. The non-encapsulated or free nerve endings, these tend to be very, very abundantly found in the epithelial and connective tissue. Most of those are non-myelinated. Those will respond usually to temperature, pain, or light touch. And this table is showing an example of some of the receptors as they're classified by structure and function. Showing some of your non-encapsulated here, like your free nerve endings, some modified free nerve endings, your hair follicle. The encapsulated endings or encapsulated dendrites, basically. Almost all of those are mechanoreceptors. And as the name implies, they are encapsulated. So this will include things such as your Meissner's corpuscles, Pacini lamnar corpuscles, Bubble's corpuscles, your muscle spindles. So in terms of processing this information, survival is going to depend upon both sensation and perception. The awareness of the change, and then being able to consciously interpret that. When we look at the organization, the somatosensory system, this is going to be part of the sensory system. Somato tends to refer more towards like the skeletal muscles is one thing definitely think of. So the body wall, your limbs, your arms, your legs. It's receiving inputs from numerous types of receptors. The input's going to be sent, that information is going to be relayed towards the brain, but there's some processing that's going to be occurring along the way. It's like, you'll send it to the brain, but don't start looking at it. They start looking at it before it gets there. And so there's different levels that we have. The receptor level, that includes your sensory receptors. Circuit level refers to processing that's occurring. When we talk about the ascending pathways, it means it's going towards the brain. Perceptual level is the processing that occurs actually in those cortical sensory areas of the brain. So it's just what we mean by here, it's picking, the receptors are picking up whatever the particular sensation is. Here you are ascending up, going up the spinal cord and moving up towards the brain. And then up here in the cortex sensory area is where you're going to start having that integration and interpreting, okay, what's going on and what do I need to do about this? Adaptation just refers to a change in the sensitivity in the presence of when you're constantly receiving a stimulus. The receptor membranes become less responsive. And so therefore those graded potentials that are generated, they either decline in frequency or they stop altogether. And so it depends on what type of receptor it is, whether it's tonic, where it adapts slowly or not at all. the reason for having this adaptation is that you can walk into a room, let's say, oh, it's chilly in here, but you know, it's cold, it's chilly, but it's not life-threatening. It's not as bad that I really need to put a jacket on, but it's colder than where I came from. Does the room temperature change after you've been in there in 20 minutes? No, probably not. But are you still aware that it's cold? Probably not. You've adapted to it. Your receptors have become less sensitive to picking up that change because it's not life-threatening. Now, if it's life-threatening, you will not have that adaptation occur. Perception of pain. This is a survival and protection mechanism that warns you that there is either actual tissue damage already occurring or it's about to occur, and you need to prevent or stop further damage from occurring. Do something about it. There's a problem. That's why, from the body's physiological standpoint, that's why pain is good, to make you aware that there's some damage either already occurring or about to occur. Everyone has the perception of pain, but the tolerance level varies. So some people have, they say they're sensitive to pain. That means they have a very low pain tolerance, not a low pain threshold. What determines this? Part of this is genetic. Part of it is the response to pain medications. And there can be things like, they have found, adapt to different levels of pain. People who are in constant pain due to certain disorders, they start to adapt where they can tolerate higher levels. But part of that is going to be genetic. You know, we've all known some people who are in a situation, something happens, they have an injury, and like, how could you not know beforehand that this happened? Didn't you feel that? Oh, well, it wasn't too bad. And then you have other people who, my mother-in-law, when she had high blood pressure, and every time I used to try to take her blood pressure, anytime you put the cuff on her arm, she thought I was killing her. You know, oh, you're trying to kill me, that hurts. And it's like, I haven't even strapped it yet. So people have different levels. Visceral and referred pain. Visceral pain is coming typically from smooth muscle, abdominal muscles, etc. Typically, you don't feel it as a sharp pain. It's more of just kind of a burning, vague, achy feeling. It's often triggered because tissue stretching. Maybe there's muscle spasm. Maybe there are chemicals. Referred pain is when you have pain from one area, but it's perceived as coming from a different area. Now, what happens is that sometimes your visceral and your somatic pain fibers, they travel along the same nerves. And so the brain assumes that the stimulus is coming from one area when it's really coming from another area. And probably the classic example of this is the left arm pain during a heart attack. And this diagram shows some of the referred pains that oftentimes, if you're feeling pain up on the, it would be on your left upper, not right on the shoulder, but along the neck, right in this area here. That's often from the lungs or the diaphragm. But if it's over here on the right side, sometimes that's the liver. If you feel pain over here on the right shoulder, that's sometimes the gallbladder. Or down here, the appendix is in this general area. And so it's not exactly where the pain's actually coming from. One thing I will say about the heart, how they'll often talk about people feeling severe chest pain and down the left arm. That has been very well documented with men. Several years ago, they realized that all the studies had been done with men. women suffer a lot from heart disease as well. And they started looking at when what actually started it was realizing, hey, we didn't have enough data, but several women, there was a study and they were asked who had suffered heart attacks, who had delayed coming in for treatment. And they're like, well, they always talk about this crushing pain in the chest and the pain down the left arm. I didn't have that, so I didn't think I was having a heart attack. And they started realizing, well, okay, are men and women different? Well, guess what? Yes, we are. We feel pain differently. And so, just kind of FYI, women oftentimes, and of course this is not true for everyone, but women oftentimes, for a heart attack, they tend to feel the pain more in their lower back. From a clinical standpoint, long-lasting or intense pain can lead to pain amplification, chronic pain, phantom limb pain. Oftentimes when someone has had an amputation, they have phantom limb pain. They still feel as though, say you had your foot amputated, as though the foot is still there, and it takes a while to kind of adjust to that. They now have found that if they use epidural anesthesia during the surgery, that it tends to reduce the phantom pain. Once again, there's a lot we don't know about how all of this works. So how are the nerves structured? How are they repaired in the peripheral nervous system? In terms of structure and classification, you've got the nerve itself is considered an organ. You have a bundle of myelinated and non-myelinated axons that are going to be held together by connective tissue. So I know it gets a little bit confusing because we talk about the neuron being this specialized cell that can generate an impulse. And off the neuron, you have that extension, the axon. When you bundle a bunch of axons together in the peripheral nervous system, remember we give it a different name. And in this case, we call it a nerve. So you're not talking about an individual cell. You're talking about the group, this bundle of axons. And why do we call it an organ? Because remember, an organ has at least two different types of tissues. Well, you have the nervous tissue there because it's a neuron, but you also have blood vessels there. You have connective tissue that's going to wrap around it as a sheath to help protect it. And so there are different types of tissues there to make that organ. Now there's two different types of nerves in the peripheral nervous system. You have spinal nerves and the cranial nerves. And the name is given to them to distinguish where did they originate, the peripheral nervous system is connected to the central nervous system. So it's going to be, where do these nerves connect, the PNS to the CNS? Now, if we look at this connective tissue covering these blankets, if you want to think of it that way, that's wrapped around them, you have three different layers. You've got the endoneurium, perineurium, and epineurium. Some of these prefixes should start to look familiar to you. The endoneurium is this loose connective tissue that's going to wrap around an individual axon. So you have an axon, it's got its myelin sheath around it, and then around that you have the endoneurium. And then the perineurium is when you take a bundle of these nerve fibers. A bundle of them is called a fascicle, and you're going to wrap that with connective tissue that's called the perineurium. And then when you take a whole group of these fascicles and wrap around that, that is the epineurium. That is what makes up what we're calling a nerve. So hopefully this will be clarified in this picture. Way up here you've got your axon, this little thin yellow line. That is the axon from one neuron. Remember, you've got this myelin sheath, the swan cells that wrap around it to provide insulation. So it's kind of like this is you, and you've put on a shirt, but it's kind of cold, so now you got to wrap around that a jacket, a sweatshirt, let's say. And then you're with a whole group of friends at a game, and it's really cold, so now you got to put a blanket around the whole group of you. You got a huge old stadium blanket, so you're going to wrap that around all of you. So each one of these yellow tubes, if you will, each one of this is a separate cell. So the endoneurium is wrapped around an individual cell. You bundle this group of cells together like this, and then wrap the group. What do you wrap it with? The perineurium. What do you call this group? You call the group of fibers here fascicle. It's a bundle of these nerves right here, the neurons. You take a group of these fascicles, all these bundles of fascicles, you take those, group them together, and wrap that with the epineurium. Now notice here you've got your blood vessels, your arteries and your vein, because these are living, growing, well, they're very high metabolic activity cells. They need a blood supply. They need oxygen. They need nutrients. They need to get rid of their waste. So they need to have a nice supply of blood. The whole thing is wrapped around with the epineurium to help protect it, to help hold all this together. This whole structure is what we are calling a nerve. Most nerves are what we call mixed, meaning they contain both afferent or efferent. Afferent is sensory, efferent is motor. So they are containing both sensory and motor fibers. And usually there's some somatic and visceral fibers in there. Remember, the visceral are going to typically your smooth muscles. The somatic is going to skeletal muscles. So the nerves are classified according to the direction that they're sending. So the sensory or afferent, they're picking up sensory information, so that impulse is going towards the central nervous system. And then the efferent or the motor, it's going away from the central nervous system. It's already been interpreted. It's the response. Mixed nerve, as I said, some are contain some fibers going towards the central nervous and some are moving away. I said most of the nerves are mixed. There's very few which is purely sensory or purely motor. So the different types of fibers, we kind of combine all this together. You've got your somatic afferent. So this is sensory information that's coming from your muscle, skeletal muscle, going to the brain. When it's muscle here, it's referring to skeletal muscle. Somatic efferent is motor information coming from the brain. It's a motor neuron that's going to a muscle. Visceral afferent is going to be a sensory fiber that's coming from organs, such as the stomach, the intestines, etc. And it's going towards the brain. Visceral efferent, just break the words down. Efferent, by now you know, efferent, that's motor. Okay, visceral, what does that mean? Organ. So motor means it's always going to be moving away from the central nervous system. Where is it going? Well, if it's somatic, it's going to skeletal muscle. Visceral means it's going to other organs. Ganglia, this is a group of the cell bodies or the somas that are in the peripheral nervous system. Probably the most common one we talk about is the dorsal root ganglia that you've already seen associated as the sensory neurons are about to enter into the spinal cord. So it's right after the spinal nerve comes, it separates, and the dorsal root nerve is one that comes around on the back side of the spinal cord, carrying that sensory information. There's a swelling that's called the dorsal root ganglia because that's where all the cell bodies are. Mature neurons are amitotic, meaning they usually are not going to go through mitosis anymore. But if the soma, if that cell body is remains intact and a nerve has been damaged, then the peripheral axon may regenerate, but only if it's in the peripheral nervous system. The nerves do not regenerate in the central nervous system, and that is one of the problems that we have in trying to deal with treatment of severe brain injuries, severe spinal cord injuries. But in the peripheral nervous system, the axon, if it's been cut, it can, not always, but it can under some circumstances regenerate. Your central nervous system axons, most of them will never regenerate. There's certain growth inhibiting proteins in the oligodendrocytes that prevent the fibers from regenerating. And the astrocytes tend to form scar tissue. Now there's a lot of research that has been going on, seeing if there's a way that we can, this is going to sound a little odd, can we inhibit the growth inhibiting proteins? These growth inhibiting proteins stop growth. So if we can inhibit this, then maybe the nerve could grow. And so that's where they're looking at a lot of research. Basically, is there something when somebody has neural damage of the CNS, can we find ways to prevent the formation of scar tissue and stimulate somehow those nerves to regenerate, so that then that can help with the recovery? They're working on it. We're not there, but we're working on it. So in the peripheral nervous system, like I say, as long as the soma remains intact, the axon sometimes can regenerate. And so how does this occur? It's a multi-step process. First, you've got those axon fragments. So you've had a break right here. The cut axon basically seals himself off, so you're going to have sealing. This is right around where you would have had that myelin sheath. Here's the yellow is the axon itself. You can see it's been cut, it has been damaged. The ends where the cut occurs start to swell up a bit. The axon is going to start to break down on this end because it's not attached to the soma anymore. It's not receiving any help from there. So the distal end of the cut axon will degenerate. It's kind of like you've cut off the food supply there. The Schwann cells and the macrophages, so the Schwann cells that were wrapped around providing that insulation, they're going to help with basically like cleanup crew. Macrophages, which are cells here that are specialized, they are stimulated whenever there's an injury to come to that site, and they are going to help also clean up any cellular debris that's there. If you had a cut there, they're also recognize anything that's foreign to try to prevent infection. Now the macrophages, as they're disposing of any of this debris, basically they're coming in and just eating it up. They will also release certain chemicals that in turn are going to stimulate those Schwann cells to start to divide. The axon filaments will start to grow. As you can see here, they start growing. The Schwann cells release these growth factors that are encouraging the growth. The Schwann cells are kind of lining up, trying to make this tube. That inside of it is where the axon originally was found. It's going to be called the regeneration tube. It's trying to help line the pieces up. If you're going to regenerate that axon, you need the pieces to line up. So once the axon has regenerated, you form this new myelin sheath around it, and hopefully it has all lined up properly. But that's only in the peripheral nervous system. Like I said, there's research going on. If we could just get this to work, think of what a huge, huge, significant step forward that would be if we could get the spinal cord, anyone with spinal cord injuries, oh, that would be such a wonderful thing if we could just get them to regenerate. The cranial nerves, these are part of the peripheral nervous system, but they do connect to the brain. That's why they're called the cranial nerves. Remember, we call them by where they originate. So even though they're connected to the brain, they're part of the peripheral nervous system. The two systems have to be connected and talk to each other. There's 12 pairs of them. 2 are attached to the forebrain, the rest are with the brain stem. Most of these are mixed nerves. We number them 1 through 12, and we use Roman numerals as we give them a name in the number. There's different ways that little phrases you can use to help you remember. Just find what works best for you. You may make one up that works best for you. I don't know. If we look at the brain, so you're looking underneath. Here's the down here would be the spinal cord. Here is your medulla. You've got the pons. Up here you've got the cerebellum. You've got the cerebrum. Most of the mass of the brain, remember, is the cerebrum up here. So if we start up here at the front, and then we number them moving back towards the spinal cord. So we're going to start up here, move back through the brain stem where the rest of them are, down the spinal cord. So right up here, these this is the olfactory nerve. It's number 1. It has this large swelling here that's known as the olfactory bulb. And then you can see how it extends down this way. And pretty much they're numbered in order as you move down. The optic nerve is number 2. That's right here. And this is the optic chiasm, where some of the nerves, when we study vision, you'll notice that this is where some of the nerves will cross over. Ocular motor nerve is number 3. Number 4 is the trochlear nerve. Trigeminal is number 5. Abducens is number 6. If we move over here, this is the facial nerve, which is 7. Vestibular cochlear nerve is number 8. Move down here, number 9, glossopharyngeal nerve. Number 10 is the vagus nerve. Slide over here, the accessory nerve for number 11. I'm sorry, right here. And then, so come down this way, and then right there is the hypoglossal nerve, number 12. So come down this way, then jump here, come down, and then the last one right here, the hypoglossal nerve, number 12, is this one off. It's off the line from here, but it's centered right there. So this table shows another way of trying to remember them in terms of whether they're sensory, motor, or both. My main thing is, can you identify the nerve, both by number and name? The names oftentimes will tell you what they're involved with. Olfactory is going to be dealing with smell. Optic is obviously going to be dealing with vision. The cochlear is going to be dealing with hearing. Facial nerve deals with some of the facial movements, etc. The spinal nerves are those that are attached to the spinal cord. Now there's 31 pairs of these. These are all mixed nerves. They will supply all of the body parts except for the head and part of the neck. And why is that? Because those are served by the cranial nerves. Of these 31 pairs, how are they divided up? They're divided by where they are named by where they come out of the vertebral column, between which are your vertebrae. So you're going to have 8 pairs of cervical nerves because you have 7 cervical vertebrae. Well, at the top there you can have the first C1 nerve comes out above the C1 vertebrae, and then you have one that comes out underneath it. So you have 8 pairs of cervical nerves. You have 12 pairs of thoracic nerves, 5 pairs of lumbar nerves, 5 pairs of sacral nerves, and just 1 pair of the coccygeal nerves, which are quite small. So like I said, you've got the 7 cervical vertebrae, but you have the 8 pairs because they come. You've got C1 nerve, C1 vertebrae, C2 nerve, C2 vertebrae on down. Each of the other spinal nerves are going to be exiting inferior to the vertebrae for which it is named. So you can see up here how it's divided: the cervical, thoracic, lumbar, sacral, and coccygeal nerves. Plexus just refers to a network. So where you have this grouping, instead of the fiber nerve coming out just one at a time, innervating where it needs to go, notice how it kind of forms this network. Almost like a little spider web, if you will. That's what a plexus is. Each spinal nerve is connected to the spinal cord itself by 2 roots. Remember, you have the spinal nerve coming up, and then it splits into 2 roots. The ventral root contains the motor fibers. The dorsal root contains the sensory fibers. Excuse me. So here, you've got a pair, so you've got one on either side. Here is the body of your vertebrae. So here's the spinal cord in the middle of it. Here is your spinal nerve here coming in. There's your dorsal root ganglia. That's a good landmark, that swelling, so you can get your bearings as to which way you're looking at. So this is the spinal nerve. It comes in, it has that branching. Here is your ventral root. Here's your dorsal root. So that's going to be sensory, sending the information in. Motor information is coming out of the ventral. But notice right before it gets to the spinal cord, you have all of this branching. We call this the rootlets. It firmly attaches the nerves then to the spinal cord. So the spinal nerve is going to be coming out of the vertebral column through the intervertebral foramen. The spinal roots become progressively longer, superior to inferior as you go down the cord. So your lumbar and sacral roots are very long. The spinal nerves themselves usually are short. You have different ramas, which are different branches of them. As you can see here, the spinal nerve here, and then here is here's the spinal nerve right here. You have the ventral ramus, you have the dorsal ramus right here as it starts to then go innervate where it needs to go. This is with the intercostal ones. Now, what's the difference between roots and rami? Roots are going to lie medial to and from the spinal nerves. The rami lie distal and are lateral branches to it. You have, as I said, these nerve plexus. There's 4 main areas: the cervical, brachial, and then the lumbar and sacral areas. Within the plexus, you have fibers that are crisscrossing. This way, each branch has fibers from several different spinal nerves. It kind of ensures that you get good innervation, good communication. You don't have just one nerve innervating or stimulating, say, one muscle and that's it. You have several different nerves coming from several different areas, so that if there is damage, say to just one spinal nerve, because you have this plexus coming in from several different nerves, the extreme branching, then damage is not going to cause complete paralysis. ideally. It's kind of like you have, let's say in a community, regardless of where you live, if you have, let's say, a hospital, obviously is going to need, be very important for a community. Do you have just one road getting to a hospital? No. So that if there is flooding and one road is flooded, or you've had an accident and it shuts down a road, do you have any other access way of getting to the hospital? Well, I certainly hope so. Most hospitals are built where they're more in a central location and you have multiple roads that you can access that hospital. It's kind of like that the nerves, you have multiple nerves coming down and innervating each of your muscles. It's kind of like have a backup plan. The cervical plexus and the neck, the C1 through C4 form that cervical plexus. Excuse me. You tend to find the plexus in areas that are innervating, like the limbs. So you have the brachial and the cervical, the limbs, and then the lumbar and sacral innervating the legs. It's where your arms and legs are located. You've got to have a way to send the nerve impulse down. The phrenic nerve, this is a major nerve that is innervating or stimulating the diaphragm, which is necessary for you to breathe. So whenever you hear phrenic nerve, think diaphragm, breathing. So this is showing how they come up. But see how you have all this branching? And some of them loop around. Don't put all your eggs in one basket. And then here's the phrenic nerve right here. This table goes through the different branches of which nerve innervates where on the body. I am not going to ask for my course that you know, okay, this is where the C2 and C3, what they do. I say, no, the phrenic nerve innervates the diaphragm. This is one of those areas. Do you have to know which nerve? Well, let's say you end up working for a neurologist. Well, over time in practice, then you're going to have this down. Irritation of the phrenic nerve, that's what tends to cause spasms in the diaphragm. And how does that present itself to you? As hiccups. Why does the irritation happen? Who knows? If we knew, then nobody would have the hiccups. If both of the phrenic nerves are severed, or if you have damage in the C3 to C5 area of the spinal cord, then that diaphragm will become paralyzed. Now, if it's just one of the phrenic nerves, then you could still breathe okay. But because remember how you have several nerves innervating, it's C3 through C5. If all of those are damaged, then yes, the diaphragm is going to become paralyzed. What happens then? You stop breathing. The only way you're going to be able to stay alive is to be on a respirator, where the machine has to breathe for you. The brachial plexus, this is going to be basically innervating your arms. It does go through the several different areas here of how you have the trunks, etc. And it gradually gets smaller and smaller and smaller. And this shows how it spreads out from the trunks divide to the divisions, which divide to the cords, which divide to the major terminal or peripheral nerves. Basically, once again, think of it as, if you want to equate it to a road map, is that you have your interstate coming off here, then you go to a divided highway, to an undivided highway, to just a regular road, to your farm to market roads. So those nerves are going to eventually come down. Some of your more important ones that you'll see most often or deal with, the axillary nerve. Think about where axillary is. It's basically your armpit. Musculocutaneous, your medial nerve. Learning the names of the nerve, which we tend to focus on more in lab, um, they're often named for the area once again, which goes back to very beginning, learning those anatomical terms for the regions of the body. If I say axillary, you should hopefully by now know where I'm looking at. If I tell you to find the ulnar nerve, well, you should be able to find that. Do you know where the ulna is? Well, look near there, in the radial nerve. So if I ask you to find the ulnar nerve, which of course is right here, don't be looking up here. That's not where we're at. This is just a description of these nerves, where they're found, what they innervate. Injuries to the brachial plexus are somewhat common. If it's a severe injury, it tends to weaken the upper arm limb, the arm itself. Depending on how severe the injury is, whether or not it will paralyze it. If you stretched it, sometimes that causes injury. A blow to the top of the shoulder can force the humerus down. That can cause injury to it. Excuse me. Maybe you fell and you hit your arm really hard. That might cause injury to it. If you hit your elbow, or as what most people call striking the funny bone, the spot is where the nerve rests against part of the bone. When you hit that, it makes typically your little finger tingle. It hurts. There's nothing funny about it. You have hit that nerve, and you are going to know that you have hit that nerve. The lumbosacral plexus and the lower limb, as I said earlier, both the lumbar and the sacral plexus individually will supply the nerve functioning for your legs. The femoral nerve, think of where the femur is. Once again, if you were to see a diagram here, can you find the nerve? Here's the femoral nerve here. And the sacral plexus is also serving the lower leg, the pelvic structures. The sciatic nerve, this is the longest and the thickest nerve in the body. It's going to innervate your hamstrings, your abductor magnus, most of the muscles in the leg and the foot, and it extends all the way down to your toes. So this is the sciatic nerve right here. And then it branches here. So eventually it comes all the way down here to your foot. And there's a table with the summary information for the lumbar plexus and then the sacral plexus. From a clinical aspect, clinical applications, sciatica, this is a fairly common problem. It's more common than a lot of people realize. You tend to feel kind of a stabbing pain all down the sciatic nerve, and actually your foot may become numb. What causes this? Well, maybe you had a fall, you had some injury. And there, obviously numerous things that could happen with that. One thing I will say with sciatica that they have found is truck drivers tend to have a lot of problems with this. That profession tends to have a higher number. And if you stop and think about it, what do? They're sitting all day driving their big rigs. They're putting pressure on that nerve. One thing that they will usually recommend if you are diagnosed with sciatica, something that may help relieve the pressure on that nerve. Like I said, oftentimes it's not caused by, but there's been injury, and sometimes it's extra pressure because you're sitting all the time. You're putting that pressure on that nerve. So they may recommend, if you're at a job where you're sitting all the time, get up and walk around periodically. The other thing is, and this may sound strange, but especially for men, one thing that they have found
is that if you're going to be driving a lot, where do you keep your wallet? And most men tend to keep it in their back pocket. And then you're sitting in the car and sitting, in the driver's seat driving, or well, it doesn't matter whether you're driving or a passenger, you're sitting, and you've got the wallet in your back pocket. Now, you may not think about it a whole lot. And even if you don't have a lot of money in the wallet, there's enough there that it kind of gets you off balance a little bit. And it's going typically to put a little bit more pressure on the sciatic nerve on the other side. So what the recommendation is, if you're going to be sitting for a long time, such as driving, don't put anything in your back pocket. That way you're sitting more even. Innervation of the skin. Dermatomes. Dermatome refers to an area of the skin that's stimulated or innervated by essentially a single spinal nerve. And most of your dermatomes are going to overlap, so that if you have an injury and damage to a single spinal nerve, it's not going to cause complete numbness. So you can look at these areas, anterior view versus posterior view, and in general, where the different spinal nerves innervate. One thing that they have found with the dermatomes is that if you're doing surgery, it seems to heal better if you cut along some of these lines instead of across them. Peripheral nerve endings. The motor endings. The peripheral nervous system, what happens is down the motor neuron, so you've had your receptor pick up the stimulus, the sensory neuron sent it to the central nervous system where the integration occurred in the appropriate area of the brain. If it went to sensory cortex area to be analyzed, then an association area, and you've analyzed this is the response that we need to do. It sends the information back down through the motor neuron. What happens at the end of that motor neuron? They have to activate an effector. The effector is going to be the actual thing giving the response. How do they activate them? They release a neurotransmitter. And so what's the effector? Like I just said, it's going to be the thing that responds. It can be a skeletal muscle if it's somatic. It can be a visceral muscle or a gland if it's visceral. So where does the activation take place? At the neuromuscular junction, where the neuron comes in and connects with the muscle. Now, it's not directly touching it, but it can stimulate it. The neurotransmitter, such as acetylcholine, is going to be released when the nerve impulse reaches that axon terminus. You thought we were done with this, didn't you? Oh, this will never go away. I know all of you just love thinking, oh, here we go with the nerve impulses in the neuromuscular junction. So here's the axon of the motor neuron. It's coming down. Here's your action potential. I know all of you are going, oh no, here it comes again. Yep, here it is. Here comes the action potential coming down. This is the end of your motor neuron. What is this? This is the muscle. That's the effector. That's the one that's having the response. So here is the axon terminus. Remember, the action potential comes down, opens up your voltage calcium gates, influx of calcium. That triggers the vesicles, synaptic vesicles, to move, and they are going to release the neurotransmitter, which in this case is acetylcholine, into the synaptic cleft. It's going to diffuse across the synaptic cleft. It's going to bind to these receptors, which opens up the chemical gates here, allowing sodium to come flushing in, which is going to generate the greater potential here, and eventually, hopefully, the action potential if you reach threshold, and boom, you're eventually going to get your muscle contraction. The acetylcholine is going to be broken down by acetylcholine esterase, removed off, which closes this chemical gate to stop the contraction. But the muscle in this case is the effector. It's going to be the thing that's responding. Autonomic motor endings are going to be stimulating visceral effectors. They're much simpler. The branches form synapses, basically kind of what we call en passant, which is in passing. The varicosities areas. Acetylcholine and norepinephrine can act indirectly as second messengers. The motor responses with the visceral tend to be slower than your somatic. Once again, somatic, think skeletal muscle. So here are your autonomic nerve fibers. You have these little swellings, if you will, right in here. They're called varicosities. Inside these is where you have your synaptic vesicle, which will release the neurotransmitters. Now, when we talk about reflexes, inborn reflexes or intrinsic ones, they're very rapid, they're involuntary. They can be modified by learning, they can be modified by conscious effort, but overall they're involuntary. An example is your posture. You did not have to learn how to maintain your posture. That was inborn, it was intrinsic. Now, you can adjust it with conscious, oh, I'm slouching. Okay, let me pull my shoulders back. Let me, sit up straight. So you can adjust it and modify it by learning, but nobody had to teach you how to do that. A learned reflex is the result of practice and repetition. If you play the piano, if you drive, cook, things like that, that's going to be learned. What are the components of a reflex arc? There's 5 steps. You have your receptor. That is what receives the stimulus. It sends activates or sends that information to the sensory neuron, which is then going to send that information to the central nervous system, and in the integration center, it's going to analyze that information. Oh, we have to have a response, send that to the motor neuron, which then sends it down to the effector to get the desired response that you want. Either a skeletal muscle contract, so you can move your hand, or to stimulate a gland to start secreting maybe a hormone. It could be stimulating a smooth muscle to start contracting. The reflexes are going to be classified by function in terms of somatic reflex that activates the skeletal muscle. In an autonomic or visceral reflex, that is going to activate smooth muscle, glands. It can have some effect on cardiac muscle. Now, cardiac muscle, when we study the heart, you'll find that you have pacemaker cells that are controlling the rate at which the heart is contracting and the fact that it is contracting. You can make some adjustments to the heart rate with certain reflexes. And this is just showing this in a kind of a picture diagram type thing. The stimulus here, okay, this nail or pen has stuck on your skin somewhere, on hand, whatever. And so you're picking up the stimulus here. So the receptor, these free nerve endings right here that are in the epidermis and the dermal layer right here are picking up. They're sending it down. The sensory neuron ends up in the spinal cord, or there's integration center. Okay, we're detecting pain. We need to do something and move your hand. Motor neuron down, it stimulates the effector, which in this case is going to be a skeletal muscle, contract so you move. That's the peripheral nervous system.